will go and act on the muscarinic receptors, M3 receptors in the GIT, and it will increase the peristaltic activity. First thing. Second, it will increase the secretions, because if you remember, we discussed that acetylcholine-like drugs increase the GI secretions. So when the GI secretions will increase, the intestinal motility is increased. So what will happen? The patient will pass the stool. So first he will pass the gas and then he will pass the stool. So that is its use. Second use is same, urinary retention. The contraction of the urinary bladder is reduced. It becomes more relaxed when there is surgery, especially it is more common in gynae, in female surgeries. The uterus become, the uterine become, the urinary bladder become more relaxed. And one of the reasons may be the drugs which are given to deliver a baby. So, what is the complication? There might be urinary retention. The patient is unable to urinate. Again, we use these drugs when there is no obstruction. There is no blockade. Like in males, we first check the prostate gland. If the prostate gland is enlarged, then we don't use these drugs. Why? Because the urethra is blocked. But if it is due to atony, atony means the contractions are absent in the urinary bladder, then we use these drugs. And they are very effective. Again, bethanycol has got two uses. First one, post-op ileus. Second one, urinary retention. So if you get question on your exam, that the patient is admitted in the hospital for the baby delivery and she got urinary retention. So which of the following is the drug of choice? So the answer should be bethanycol. Bethanycol will be used. Same with the post-op ileus. Okay. Next one is open angle glaucoma. What is glaucoma? Did you discuss glaucoma in medical terminologies? Marvin? Glaucoma. Try to understand what is important for us, that as we measure the blood pressure, how we measure the blood pressure? You go to the hospital, or sometimes we have the BP apparatus at home, digital. So we wrap it here on the wrist and then look on the readings. Normal blood pressure is how much? BP. Normal blood pressure is 120/80 mmHg.
Eye disease?
Sorry?
Eye disease?
Glaucoma is eye disease, yeah. What is important, I'm coming to that. It is eye disease. If it is not diagnosed on time, unfortunately, there is blindness and irreversible blindness, because it will damage the optic nerves. Okay, what is important, why we need to use this drug, that like we have blood pressure, similarly we have pressure in the eyes, and that is called IOP, intraocular pressure. What is that called? IOP, intraocular pressure. So normally this intraocular pressure, we check it with tonometer. It is from 18 to 21 mmHg. This is normal value. This is normal value. If a patient comes to you, normally, unfortunately, it is very late because mostly symptoms are not there. The one symptom that is there, that there is pain in the eyes. So the patient comes to you, you are ophthalmologist, and patient says, doctor, I feel pain in the eyes. So the ophthalmologist, being an ophthalmologist, what you will do? You will do tonometry, you will check the intraocular pressure. So you will find that the intraocular pressure is, for example, 30 mmHg. So what does that mean? That the patient is suffering from glaucoma. And these drugs, like normally we use carbachol and pilocarpine in eye drops, they will reduce this pressure. They will reduce this pressure to 21, 22, 23, maybe something like that. So that is the second use of the muscarinic agonist, that it is used in open angle glaucoma. There are two types. One is called open angle and the other one is called narrow angle glaucoma. The next one, can you help me to pronounce? As you know that sometimes same will be in the Arabic. Some words are silent. When you even read Quran, some words are silent, especially when you join to the next word. Similarly, in English, you know, mashallah, all of you speak very good English. So some words are silent. Here, one word is silent. Either S is silent or J is silent. So what do you think?
J.
J is silent. Okay, so what you will say?
J.
J. So what you will say?
Sagra.
Okay, Sjogren. Okay. And some people say no, S is silent. So if S is silent, then what we will say?
Jogren.
Jogren. Okay, so both way, because sometimes, inshallah, when you will travel abroad, you will find both type of doctors. Most of them, especially Americans, they say Sjogren.
هذا مشكلة طيب.
You will go to America.
لا.
No, you must go. They are the best in education. We must take benefit of their education, isn't it? And then come back and serve.
في كذا.
And fight against Israel. Karam is happy. Okay. And so both way, Sjogren or Jogren. What is the problem? First thing, it is autoimmune disorder. Autoimmune disorder. What do we mean by autoimmune disorder? That our own antibodies, they become our enemies. Our own antibodies become our enemies. So they attack different parts of the body. Here what happens that they attack the lacrimal glands. Lacrimal glands are the ocular glands, eye glands, they are attacked. What is the function of the lacrimal glands? That they secrete tears. Okay, so what will happen in Sjogren? When they are blocked, there will be no tears. So the patient will complain dryness of the eyes. Sjogren, the patient will complain dryness of the eyes. So how we can correct it? By giving pilocarpine eye drops. We instill eye drops into the eye, morning, afternoon, evening, and by this follicle we can correct. But this is unfortunately lifetime problem. You know, autoimmune disorders, you can only manage them, you cannot treat them.
Chronic.
Chronic in the sense lifetime. Only thing that you can do with them, just give the drug and manage the things. Sometimes even with drugs it doesn't work. But as research is going on, they are bringing these monoclonal antibodies. You might have discussed with Dr. Abdul Rahman. They also work, but they are very expensive. Many times the patient cannot afford. Anyhow, the simple thing that we can do, that we give pilocarpine. The last one in this is methacholine asthma challenge test. Methacholine is the muscarinic agonist. Where do we use it? We use it in diagnosing the asthma. Asthma challenge test. Sometimes, especially in adolescent, when the child is entering into the puberty, maybe 10, 11, 12, 13 like this, and is frequently suffering from respiratory tract infection, and cough is there, sneezing is there, difficulty breathing is there, and the pediatrician is unable. Yes?
بالمحاضرة.
Yeah, I have sent this. The pediatrician is unable to diagnose whether this is asthma or something else. First thing. Similarly, like those who smoke more cigarettes, later on though they suffer from respiratory problems. Now to differentiate whether this is asthma or some other respiratory problem like COPD, we will discuss in next slide. So to differentiate that, what we do, that we give the patient methacholine. We administer methacholine to the patient if the symptoms appear. Symptoms of what? Difficulty breathing, coughing, then we say this is asthma. If the symptoms appear after giving methacholine, then we say this is asthma. You give the patient methacholine, no symptoms appear, it means it is not asthma. It is a respiratory tract problem, but maybe something else. So that is called methacholine challenge test, that you give or administer methacholine to the patient, wait for 1 hour. After 1 hour, when you check the chest from back and front, you listen wheezing, whistle sounds on back and front with the stethoscope, then oh, this is asthma. If there is only difficulty breathing, nothing, you gave the methacholine and you don't find anything, then it is not asthma. How much it is useful, this is another story, but this is the test that is used. It is a diagnostic test. So if you get question on your exam, that which of the following muscarinic agonist is used for the diagnosis of asthma? So the answer should be methacholine. Okay? Side effects are cholinergic side effects, as we discussed already, dumbbells or sledge. All the side effects that whenever acetylcholine level is increased in the body, they will happen. But again, keep in mind, these side effects, they will be different based on the route of administration. If you give the drug oral, they will be different. If you use the drug injectables, injection, intramuscular, IV, they will be different. If you instill it into the eyes, the side effects will be different. When you will instill it to the eyes, the side effects will be minimum. Like you see, these Sjogren patients also come to dental clinics. Why? Because they have this problem, dryness of the mouth. Dryness in the eyes, dryness of the mouth. So dryness of the mouth then leads to different dental problems. So you will see these patients and they will tell you that, especially they are females, unfortunately you know, mostly autoimmune disorders, they are more common in females. So they will tell you that I'm using this drug for the last 5 years and she will not complain any side effects. If any side effect, that will be local, like excessive lacrimation. That's it, but not the other side effects like suffering from bradycardia. Sometimes it is possible if she is taking overdose or larger dose, or diarrhea, or hypersalivation, all these things, they are normally not there. Okay? Next, acetylcholine esterase inhibitors. Here, this is the enzyme that is responsible for the breakdown of the acetylcholine. As we know that acetylcholine is the primary and secondary neurotransmitter of the parasympathetic nervous system. And when it comes to the plasma, its half-life is very short. I am talking about physiology, Dr. Ayman. when it comes to the plasma, its half-life is very short. Why its half-life is very short? Because this enzyme that is called acetylcholine esterase enzyme, ACHTREASE. This enzyme, it acts on the acetylcholine, and this enzyme breaks down the acetylcholine into choline and acetic acid, your favorite biochemistry. Mazboot? You got the point? Or Mafi? Repeating. Normally, whenever the acetylcholine is released into the plasma is blood. You know that all the liquid part of the blood is plasma. Okay? The formed elements are RBCs, white blood cells, and platelets. So the drugs, they are in the plasma. And mostly the drugs will bind to plasma proteins. Which protein do you remember? Which protein in plasma proteins? Albumin. Albumin. Okay? So what happens when the body secretes acetylcholine in response to, for example, some drug or some other activity, physiologically, because we need it during parasympathetic activity. The body itself releases. So when it comes to the plasma, in the plasma there is enzyme, and this enzyme is called acetylcholine esterase. So this enzyme will act on the acetylcholine, and it will break down the acetylcholine into choline and acetic acid. Got my point? So what happens that acetylcholine is finished? Why? Because the enzyme acted on it and it has broken down. Okay? So what we have now, we will block this enzyme. We will block this enzyme. So when this enzyme will be blocked, what will happen to the acetylcholine?
There will be no breakdown.
Very good. There will be no breakdown of the acetylcholine. Why? Because the enzyme that is responsible for the breakdown of acetylcholine, you blocked that enzyme. So when the enzyme is blocked, what will happen that the acetylcholine level will be there, or it will keep increasing. Why? No one is there to block it. But here one thing very important, that we cannot block these enzymes for longer duration. It may be 1 minute, 2 minutes, 1 hour, 2 hours, 1 day, 2 days, 7 days, khalas. More than that, then there is problem. Keep in mind, they are very effective, they are good, blah, blah, blah. By the end of the day, there must be a limit. There must be a limit. It should be 1 day, 1 week, but not more than that. Why? Because if it is for longer duration, then there is problem. What is problem? We will look to that. So we divide these acetylcholine esterase inhibitors into 2 groups, reversible and irreversible. So reversible is that you block the acetylcholine esterase enzyme, for example, for 2 minutes, 2 hours, or 24 hours, like that. After that, what will happen? That acetylcholine esterase enzyme will start, and it will act on the acetylcholine. But it will be for certain period. So that is called reversible. Who are the reversible? We have, please help me to read, please. Anyone can help? Okay. Next one. Okay. Next. Okay, pyrostigmine, pyridostigmine, okay, and hydrophonium. Okay, neostigmine, physostigmine, pyridostigmine, and Adrophonium. Just drugs. Just focus. Which one is different? The last one. The last one is adrophonium. Adrophonium. The other three are means. Neostigmine, physostigmine, and pyridostigmine. Clear? Okay. Why I say that focus on it, you will find the difference. Mechanism of action, we discussed that they will inhibit the acetylcholine esterase. Okay? Acetylcholine esterase will be inhibited. So when it will inhibit, it will increase the acetylcholine in the nerve terminals. From plasma, it will go to the nerve terminals and it will be increased. That is the mechanism of action. Now, first one, where do we use these all bloody drugs? Because their names are difficult. Neostigmine, physostigmine, pyridostigmine, and adrophonium. Where do we use them? First one, we take it from the reverse. Look at the first one, diagnosing. Please help me. Yes. Diagnosing myasthenia gravis, adrophonium. Myasthenia gravis. Myasthenia gravis. What is myasthenia gravis? The drug that is used to diagnose is adrophonium. Very good. What is myasthenia gravis? Maya means muscles. Muscles. Tinea means weakness. Weakness of the muscles. Gravis means severe weakness of the muscles. Which muscles? Especially facial muscles or eye muscles. Now, two things happen. When the patient suffers from myasthenia gravis, again, unfortunately, you will think that I'm in Saudi Arabia and putting the female pictures. Because myasthenia gravis is autoimmune disorder. Autoimmune disorders are more common in females. So, the patient will tell you, both way possible, the doctor, when I look at you, I find 4 eyes, 2 noses, 2 upper and 2 lower lips for you. When the patient look at you, the patient will tell you that, doctor, I find 4 eyes. Here you see 2 or 4.
Every time?
Huh?
Every time?
Every time. So life is miserable, isn't? The second thing, so the first thing, when he will start complaining this, she will start complaining in the beginning that whenever I look at things, for example, car is going, so to me it looks maybe 2 or 4, although it is 1 car. So there is always accident. They can't drive, believe me, because they can't focus.
Okay.
So this is called diplopia. Diplopia. Double vision. Double vision, when you see things as double. So this is first thing. Second, the patient will tell you, doctor, I lose the control of the eyelids. When you lose the control of the eyelid, what will happen? Even it will close and you cannot open the eye. Eyelid control is gone, you cannot open the eye. So this is called myasthenia gravis. In third, then it will come to the face, to the lips, that will be damaged. Mostly it is the facial and the eyes, they are damaged. And then it becomes later on systemic. Now the point, if you see, I wrote before and after. Before, the patient is in your clinic and she is having, this is called ptosis. Ptosis means that the eyelid will close down. Again, there is P is silent. ptosis. Ptosis. Okay? So the patient is with you and the eyelid is falling down and the one eye is closed. Normally one side is affected. So you think that one of the possible diagnosis is myasthenia gravis. There could be other problems like you will discuss inshallah with Dr. Ayman later on, like Bell's palsy, paresthesias, facial palsies, where there may be the same symptom. Now you want to confirm that this is myasthenia gravis. What you do? You take adrophonium from your drawer, injection, and give this injection in the eye here on the upper lid. You see, within 2 minutes what happens? Ptosis is gone. And now she is normal lady. Mabruk.
Alhamdulillah.
Alhamdulillah.
She can drive.
Now she can drive and go to a home. But you should not go home. You stay with me. Adrophonium is diagnostic. But this effect is only for 5 minutes. Only 5 minutes. Why we use? Just to diagnose that the patient is suffering from myasthenia gravis. That's it. We don't use it that, okay, this is your medicine and take it every day. Every day it doesn't work. Why? The duration of action is very short. 5 minutes is nothing, isn't it? So we will give other drugs like neostigmine, paradostigmine, physostigmine, but just to confirm that this is myasthenia gravis, we will give injection adrophonium. Clear? So if you get question on your exam that the lady is presented in your clinic and you want to assess or to diagnose myasthenia gravis, which of the following should be the drug? It should not be neostigmine, not paradostigmine, not physostigmine. It should be adrophonium. Okay, go to next. Ileus and urinary retention, neostigmine. Like you will find that sometimes carbachol is not available. If you go back to this slide, we say that betanicol and carbachol, they are used for post-ileus or urinary retention. Now, in the hospital, betanicol is not available. Why? Because mostly betanicol is used for veterinary purposes. What is veterinary? Yes. For animals, mashallah, good. For animals. So mostly large ampules, 50 ml, 100 ml ampule, are vial, big vial. So we use it in animals. We don't have, for example, I don't say that it is not available. Sometimes it is not available in the hospital. So the other option that we have, that is the, where were we? Yes, that is the neostigmine. Neostigmine can be also used to treat post-opt ileus and the other one urinary retention. Now try to focus. If you get question on your exam that the patient is in the hospital and she is suffering from urinary retention, so either it will be neostigmine or betanicol. If both are there, both are correct. You have 4 choices. Listen to the question. A female patient is admitted in the hospital. She delivered a baby. Now she is having urinary retention. So which of the following should be used? So in the option, pilocarpine, betanicol, adrophonium, and neostigmine. Betanicol, the previous slide, you were not here at that time. Betanicol, here you see betanicol. Betanicol is also used for urinary retention. And here neostigmine is also used for urinary retention. So 2 options are correct. The point is that one of them will be there. Both will not be there. If instead of neostigmine, paradostigmine is there, or physostigmine is there, then the correct answer is botanical. But if both are there, both will not be there. If both are there, means both are correct. Okay? So normally we give either neostigmine or botanical. Clear? Okay. Next, anticholinergic overdose. Anticholinergic overdose. Underline it. We will discuss it in the next slide, because first we need to know what is anticholinergic overdose. Go to next. Donepezil, the same. We didn't finish this slide. Donepezil, galantamine, rivastigmine, and tacrine. Cross this second and third one. Fourth one. Sorry, galantamine and tacrine. Mostly, we use donepezil and rivastigmine. Where we use it? We use it to treat dementia, Alzheimer. Okay? So, you have a patient in your clinic and you are dealing with geriatrics. Geriatrics means old age people. And you know all old people have tooth problem. So, and the patient tells you, or the attendant of the patient tells you, that the patient is on donepezil. So what should come to your mind? Oh, he or she may be suffering from forgetfulness or maybe from Alzheimer, because it is used in Alzheimer. There is role of the acetylcholine in the CNS, M1 and M5. Whenever acetylcholine is less in the CNS, the patient will suffer from this problem. So how we can treat this problem? By giving the drug that will block the breakdown of acetylcholine. Donepezil and rivastigmine. They are reversible anticholinesterase esterase, or they are reversible acetylcholine esterase inhibitors. This is same thing. Please try to understand. If you get on your exam anticholine esterase, it is same like acetylcholine esterase. Why? Because anti is against. So they sometimes, to confuse, we instead of inhibitors, because here on the slide it is written inhibitors. There you find, oh, this is anticholine esterase, and we didn't discuss this. So keep in mind. Okay, the side effects same that we discussed for previous slide for the acetylcholine, like botanical, carbachol, all of them, the side effects are same. Next we go to irreversible agents or organophosphates. Irreversible agents. The mechanism of action is same. They are nerve gases and ecothiophage. Nerve gases. Soman, Trabun. First, organophosphates. Organophosphates are the chemicals which are used to kill the insects. If you just look back at your house or villa, the problem that we face, cockroaches. You know cockroach. What is called in Arabic? Sir? Sarsa. Yes. Yeah. With two antennas. Yeah. So that is the problem. So how you will solve this problem? That you will use the drug that are called organophosphates. They will kill these insects. How it will kill these insects? The same happens to us. That it blocks the enzyme acetylcholine esterase irreversibly. It blocks this enzyme acetylcholine esterase irreversibly. When acetylcholine esterase enzyme is blocked irreversibly, what happens? That the acetylcholine level is increasing in the body, at the nerve terminals, in the different body systems. And what happens to the cockroach? That there is respiratory failure. There is respiratory failure. And due to respiratory failure, the cockroach dies. The same happens to human being. How during wars, nerve gases, someone like in Syria, in Yemen, I don't know whether they used, but this is one of the weapon. We say bioterrorism. People use it during wars. Why? Because it is very easy. You just spray it in the environment of that specific place. In the morning, many of them, they can't get up, die. Why? Because when we inhale these gases, they block this enzyme, and what I told, okay, 1 day, 2 day, 3 day, 4 day, 5 day, 7 day, okay, more than that, then crisis starts. What is the crisis? Then the patient will suffering from respiratory depression, and that respiratory depression will lead to death. If the dose is small, if the dose is high, the same day death. Why? Because a high level of acetylcholine we cannot manage. So that is the use of these when they are irreversible. Okay? The other one, suicide substrates, like organophosphates. They are available at almost every house, powder. They are powder. You sprinkle it in the washrooms, in the kitchens, where there you find insects, and they kill the insects. Similarly, mosquito repellents, the liquid. If you check the liquid that is in the container of the mosquito repellent, they contain the same. It is only liquid, otherwise it is same thing. So, God forbid, by mistake, if a child consume like juice, so what will happen? The same will happen. The acetylcholine level will go up. If it is not reported on time, if the dose is high, he may die. So that is the story of organophosphate. Suicide subjects. Sometimes even people used to commit suicide, and we are Muslims, we believe that suicide is haram. But still, this is life. Sometimes you find people, they commit suicide. So organophosphate is one of the chemical that is used for this purpose. Okay, go to next. Muscarinic antagonist. Muscarinic antagonist. What they will do? They will block the effect of acetylcholine. They will block the acetylcholine not to attach to its receptors. Who are the acetylcholine receptors? I am repeating: M1, M2, M3, M4, and M5. When we give these drugs, they will block the acetylcholine not to bind to its receptors. So when it will not bind to its receptors, what will happen? We will see that. So they are called muscarinic antagonists, or in bracket you can write anticholinergics. In bracket you can write anticholinergics, because they act on the cholinergic receptors. They will block the acetylcholine from binding to its receptors. Okay? Now, what will happen? That it will antagonize at the muscarinic receptors. What are the effects? First one are the anticholinergic effects. It will block the acetylcholine in the body. Wherever there is acetylcholine, they will block it. Whether it is in the brain, whether it is in the GI, whether it is in the eye, whether it is in the genitourinary system, wherever the acetylcholine acts, these drugs, based on their route of administration, will block that effect. Clear? Okay, so first thing that it will do, that they will cause pupil dilation. That is called mydriasis. What is pupil dilation? If you remember, we discussed last time that the normal pupil size, for example, is 10 millimeter. Okay? So if it is reduced from 10 to 6 millimeter or 5 millimeter, we say this is meiosis. Meiosis. If it is increased from 10 to 11, 12, 13, 14, 15, 16, 17, 18, 30 millimeter. So what will be that? Mydriasis. That will be called mydriasis. This increase in pupil size. Why it will cause increase in pupil size? Because it will block the muscarinic receptors in the eyes. Okay? So that will increase the pupil size. This term is used, pupil dilation is mydriasis. Second one is decrease in secretions. Assalamu alaikum. Yes. I'm here, yeah, from 10 to 11, yeah. Sorry? I'm here in boys. Yes. Yeah. Well. Okay. So, it will do opposite to the acetylcholine. Acetylcholine increases the body secretions. It will decrease the body secretions. Then acetylcholine increase the acid secretion. It will decrease the acid secretion, GI acid. The acetylcholine increase the GIT motility. It will decrease the GIT motility. Acetylcholine increase the we used to treat urinary retention. It reduce the urinary urgency. What is urinary urgency? I'll tell you. Okay, the uses, just try to understand first. We read the names and then go down. First one is atropine. This is the parent drug or prototype. Keep in mind, if you get question on your exam, that which of the following anticholinergic or muscarinic antagonist acts on all the muscarinic receptors from M1 to M5, the answer should be atropine. Atropine acts on all the muscarinic receptors. It will act on all the muscarinic receptors when it is given in injection or tablets. Okay? This is the important thing. It is the parent drug, it is the prototype, what I used to say, this is the imam of the group. Okay? From where it came? Atropa belladonna, not Diego Maradona. This is belladonna. Atropa belladonna is the name of the plants from which it was derived. And why the name given by Atropa belladonna? It is said in good olden days, or bad olden days, whatever you say, there was a princess, Amira, in Roman Empire, and she used certain plant, and what happened that the pupil size is increased. She didn't know that the pupil size is increased, but what happened that the eyes look bigger, because when the pupil size is increased, the eye look bigger. So you know that what is the importance of big eyes for females. I'm not going into details. Karam knows. Okay? So the name came from there, Atropa belladonna, because it causes mydriasis. And interestingly, this is when you take, for example, single dose, this mydriasis continues for 7 days. Longest acting anticholinergic. Second question, which of the following is the longest acting antimuscarinic or anticholinergic? The answer should be atropine. Atropine acts on all receptors, and atropine is the longest acting muscarinic antagonist. Clear? Okay, so the name came from there, that it was used and they found that it causes mydriasis. But that is the only thing, it causes also other things. Now, nowadays, where we do use it? First one, bring a line from atropine to bradycardia. It is used to treat symptomatic bradycardia. What is bradycardia? When the heart rate is decreased. Like you have a patient in your clinic, and the heart rate is 40 beats per minute. If you remember, I told you, you must ask the medical history. If the patient says, like our leader Anmar, that I am athlete, so for athletes 40 beats is normal. For athlete 130 beats is normal. But if you ask Karam, then the story is different. Why? Because Karam is not athlete. So for him, 40 beats is bradycardia. And you need to correct it. How you will correct? That we will give atropine injection. Atropine injection will act in the cardiac muscles and the muscarinic receptors, and it will increase the heart rate. It will increase the heart rate. But write in bracket injection. Atropine injection. The another one, bring another line, that is to the mydriasis. That it causes mydriasis. Atropine eye drops. Normally nowadays we don't use, now a new drug is used, but I don't want to burden you. Just to give you the idea, because we can use still, no problem. Atropine is used to cause mydriasis. If you recall, those who are wearing glasses like me, when you go to the first time to the doctor, to the ophthalmologist, 1, 2, 3, 4, 5, at least 5 students are wearing glasses. When you go first time, maybe in your secondary school, I don't know when you started glasses. Normally, we start from 13, 14 years. That is the time where these children say we can't see the board. Anyhow, I don't know when you started. Recall, when you went first time, and when you went there, what he did, that he instilled drops into your eye and asked you wait for some time. That means, doesn't mean that he is busy on the mobile phone, social media. He wants to give you time so that there is mydriasis. The pupil size should be increased. Fundoscopy, he wants to see if there is any problem in the eye. That is called fundoscopy. And for this we use atropine eye drops. It will cause the pupil dilation maximum up to 30 or 35 millimeter. So all your eye will be pupil. So it is so increased in the size. So that is the second use. But the difference is, try to understand, for this we use it eye drops. When we give it injectable, it will also cause mydriasis, but we don't use injectable for the mydriasis. Why? Because it causes tachycardia. If the patient is normal, the heart rate is 70 to 80, and you give atropine, the heart rate may cross 100. So that will be another problem. Next, scopolamine. Where do we use scopolamine? Scopolamine is the younger brother of atropine. But scopolamine, it crosses the blood-brain barrier. Remember, BBB. Remember we discussed, any drug that can cross the blood-brain barrier will be hydrophilic or lipophilic? Lipophilic, mashallah. That will be lipophilic. So scopolamine is lipophilic. It crosses the blood-brain barrier. So where do we use it? We use it for the motion sickness. What is motion sickness? Motion sickness, mashallah, your generation Z, I think none of you will be suffering from this problem sometimes. But if you ask your grandparents, even not your parents, grandparents, they will tell you, some of them, especially females, they say, when we sit in the car, or in the bus, or in the train, or in the aeroplane, start feeling dizziness, or nausea, or vomiting. You might have seen sometimes passengers vomiting while traveling. What happened? There is infection? No. This is motion sickness. This is motion sickness. You suffer? Yeah. You see? So The best drug that can treat motion sickness, that is scopolamine. Those who have sickness from the mountains, like me, when I traveled to Hada, it was first time and last time. Then I never traveled again by this route. Why? Because it is zigzag, so difficult. So that is mountain sickness. If you go by sea, so that is sea sickness. Aeroplane is motion sickness. Okay? So the treatment is same. We use scopolamine. Scopolamine is effective because it crosses the blood-brain barrier and it treats this problem. Go to next. Yeah. Next is ipratropium and tiotropium. In bracket, write inhalation. Bakha or nebulization. Inhalation or nebulization. It is only used by inhalation. No eye drops, no injection, no oral preparation, nothing. Only solution that is used by inhalation, whether in bakha or whether in nebulizer. Okay? Ipratropium and tiotropium. Remember, we discussed in the previous slide that sometimes we use to diagnose asthma by giving methacholine. Remember? Why we try to diagnose methacholine? Because methacholine will cause bronchospasm and it will increase the bronchial secretions. Lung secretions will be increased. It will do opposite. Why? Because it will block the acetylcholine. So when the acetylcholine is blocked, the effect on the lungs will be that the smooth muscles of the lung will be relaxed. So there will be bronchodilation. There will be bronchodilation. The second thing that it will do, it will reduce the bronchial secretions. It will reduce the bronchial secretion. So the problem in asthma as well as in COPD is these two things. First thing, that the first one is bronchial contraction or bronchospasm. The second one is that there is increased bronchial secretions. So ipratropium and tiotropium, it will act on both and they are used for this purpose. But again, keep in mind that they are used only by inhalation. They are never used by injection tablet or any other route. They are specifically used by inhalation. The last one is, what is this? Karam, please help me to pronounce.
Darafini.
Yes, anyone can help?
Darafinaki.
My teacher in computer.
Definition.
Okay. Dari.
Yes.
Dari. Vincent.
Vincent.
Dari phenacin. Dari phenacin. And you will find many sins like that. Solifenacin is also there, but we use dariphenacin. Where do we use dariphenacin? First one, we use it in BPH. BPH stands for blood pressure high. Wala maaf. Yes, and is not agreeing. Huh? So what is BPH? You already discussed it in medical terminology. Your medical terminology doctor told me I discussed with these students BPH. Benign prostatic hyperplasia or hypertrophy. Benign prostatic hyperplasia. So who suffer from this problem? Males or females? Or both? Males. Prostate gland active in males. So what happens to the prostate gland? That the size of the prostate gland is increased. Normally increase in prostate gland starts after 45 years of age. From 20 to 45 years, the prostate gland size is 20 gram. How much?
20 gram.
20 gram. After 45 years, it start to increase. 21, 2, 3, 4, 5, 6, 7, 8, 9, 10, go up to 100 grams. It depends on the situation. So, when the prostate gland is increased in size, what happens? It blocks the urethra. It comes over the urethra. So, the urethra is blocked. So, when the urethra is blocked, what will happen? The patient will not urinate, will unable to urinate. One of the reasons they say that for the increase in the prostate gland size is the acetylcholine. So what we do that we start giving the drug that will block the acetylcholine in the detrusor muscles. If you remember, we discussed last time detrusor muscles. These are the detrusor muscles and this is the trigonal muscles and these are the detrusor muscles. So it will act on both because detrusor muscles have the muscarinic receptors, the trigonal muscles have the receptors. So it will cause the contraction of the trigonal muscles, it will cause relaxation of the detrusor muscles, opposite to the acetylcholine. So you will find patients, they use this drug for long duration. If you will get patient on your clinic and you take the medical history and he says, doctor, I am using darifenacin, and the patient is male, first thing that should come to your mind, that is suffering from BPH, or benign prostatic hyperplasia. Second problem, that is called urge incontinence. Urge incontinence. It happens both in males and females, but more in females. More in females. What happens that, as we discussed, that acetylcholine is responsible, like this is the urinary bladder. When acetylcholine stimulates these receptors, whatever urine is present, whether it is small amount or large amount, when acetylcholine is stimulated, the detrusor muscles, it will contract the urinary bladder. Whether it is 5 ml, whether it is 100 ml, when it is hyperstimulated. And that condition is called urge incontinence. So what the patient will tell you, doctor, I cannot control my urination. Even I am not able to reach to the washroom. Our societies are different. Muslim societies, these Asian societies, they are different. Normally females don't share these things. But if you go to West, the young lady will tell you that, doctor, when even she coughs and there is a drop of the urine, she will tell you that my inner is wet with the urine. So sensitive. And they have their own system. The problem is urge incontinence. How we treat urge incontinence? By giving anticholinergic. Why? Because it will relax the urinary bladder and it will contract the trigonal muscles. Don't go. It will block the trigonal muscles. So unless a big amount of or volume of the urine is collected in the urinary bladder. Okay, side effects. Decreased sweating, because we discussed last time that the sweat glands are stimulated by the acetylcholine. So when the sweating is decreased, the body temperature goes up. Why? Because sweating plays an important role in the temperature regulation. Dry mouth. This is another problem that because it will block the salivary glands muscarinic receptors. So the patient will complain of dry mouth. Constipation. Why constipation? Because all these drugs, they will decrease the intestinal motility or GIT motility and will decrease the secretions. GI secretions will also be decreased. So all these will cause constipation. Then we go to next, that is called disorientation. Disorientation, if you go back, we discussed here Alzheimer's or forgetfulness. What happens when the acetylcholine level is decreased in the CNS, the patient is disoriented, confused. What is disoriented? Like now it is 10:20. And if you ask the patient what is the time, he will say that it is night time. He is disoriented in time.
Okay.
Why? Because what I told, acetylcholine plays important role in the CNS to regulate the orientation. And similarly, he will be in Makkah, but he will tell you, I am in Riyadh. Yeah, Doctor. So, what is this? This is called disorientation. Sometimes more than disorientation, confusion, forgetfulness. He will forget very small things, like coming to the university and forgot the keys of the car. So how you will drive the car? Are there is system? No, new system. So very small things. So that is called disorientation, that can lead to confusion. Clear? Then cycloplegia or no accommodation. That is another problem. When the eyes remain, the pupil remain dilated for longer duration, the patient will tell you, doctor, I feel pain in the eye. I feel pain in the eye. If you remember, we discussed one of the symptoms of the glaucoma is pain. Why? In glaucoma, the same acetylcholine level is decreased. Here you block the acetylcholine, so there will be lack of accommodation or cycloplegia or eyes pain. Next is mydriasis. The pupil size will be dilated. If you don't need for eye examination, then pupil size dilation is not good. Why the pupil should dilate for longer duration? So that are the side effects. Go to next. I think we should take break for a few minutes and then continue.